what they would assume as normal. But that would not be normal if this was a pug, for example, or depending which breed it is. Some dogs will have a much pointier kind of medial coronoid process. And other dogs, they almost have it like a bit of square, like it almost looks like a chunk is gone. If you suspect a chunk of it is missing, you must be able to find that fragment, or if it is not dense enough to be seen, then if that is so abnormal that a big chunk of cartilage is come off, you would see changes underneath. Okay, so the shape itself is not very reliable, in my opinion. And you will also find little defects in some dogs, a little kind of, I don't know if it's a vascular channel. Some dogs have like a little dimple, they're like a little hole in the tip of it. Okay, so just be very careful to overinterpret that as disease. If that is the only thing you can see, I would be more inclined towards some kind of anatomical variant. And now I've been brave because there was a bit of confusion with the starting time. If, I think it was sent as 1 p.m., but I don't know if that was BST or whatever time it was. So I've had a little bit of extra time and I decided to make a poll. So it's last minute. So chances this works nil. I've never done it before. So I'm gonna launch it now. So I want you to look at these two images here. Both abnormal or one of each. Okay, so if one of each, obviously you are thinking one is normal, the other one is not. I'm gonna launch that, see if that works. Yeah, see if someone wants to click it and I get some kind of feedback. There's 141 people, guys. It is amazing. I was not expecting a third of that. Can you, Frida, is that appearing on everybody's computer?
Can you put the yes, no buttons, guys, and tell me if you see it?
No, did it show for you?
I'm getting a lot of yeses.
Ah, okay, cool. But I'm not getting is the percentage or anything.
Okay, so I've got 81% one normal and one abnormal.
Okay.
I've got 3% both abnormal and 16% both normal. All
right. Okay, I'm gonna end the poll now. It's anonymous, by the way, so do not worry about this. I'm in a way trying to trick you. Okay, first of all, you cannot make a diagnosis obviously in one image. I'm not expecting anyone to get this right. But I've used this before starting to talk into detail about the density of a coronoid, and so that you can see this is exactly the same elbow. Okay, so kind of the only two things we can debate about is this both normal or both abnormal. I think most people generally will always go for this one being abnormal because this here looks more dense, while here we've got a sharper transition between the cancellous bone and the cortical bone. So could this be sclerosis? I think that's one of the ways people look at this. Now, if you look at the sagittal image, this scanning plane is the purple line. And between this plane and this plane, there is 0.8 millimeters of difference, okay? Now, I'm using this as an example so that you understand that any changes that you see, you need to correlate them with the sagittal plane, because the sagittal plane is a little bit like, if you see a nodule in a lung in a dorsoventral view, everybody would think straight off to go to the laterals and try to find it. CT is not all that different, okay? And the exact anatomy in this particular area in the coronoid is extremely variable and is quite complex, as we are gonna see. So a very slight change in the degrees in the plane, or a little bit going more proximal or more distal, will start to make things appear very, very different as well, okay? So I'm gonna now highlight in different colors the different areas that I'm sure all of you are aware, and I just want you to look at this in detail. So when we are looking at the ulna here, I'm doing this sagittal plane along the coronoid process. So we see the medullary cavity, which should be normally fat density, may change with age, or you will start to see kind of tubular soft tissue densities in it, which are all the vessels. But overall, we have this cavity here, which is really well delimited. So at the bottom, it contacts directly the cortical bone, and proximally is not so well defined because of all of the trabeculae and the cancellous bone, okay? So that's one part. Now, proximal to this is all the cancellous bone. I don't know what the correct terminology is. I'm not looking into this as in I'm in a microscope, but basically you do have all of these kind of thin bands of bone density with a little bit of soft tissue or fat within them. And the interesting thing when it comes to the medial coronoid process, and one of the sources of confusion and disagreements, is that, do you see here how this band of cancellous bone is extending all the way to the tip of the coronoid? You will see this if you look for it in big dogs. Sometimes in the small dogs, it is very variable, but some dogs will stretch all the way to the tip. And depending how you cut this, at which angle you cut through it, it will appear as an area of loss of density in the tip of the coronoid that may look pathological. Or it may, it may definitely cause confusion if you are cutting it at a different angle. So you need to be aware of that. And if you see any hypoattenuating areas extending all the way to the tip, just go back to the sagittals and make sure that's not that, okay? Because that is normal, but again, it is variable. You will not see this in every single dog. The other one is very straightforward. So it's all the cortical bone that goes towards the ulna, the diaphysis there. And this will generally finish kind of this shape, almost like a buttress shape. And then you have exactly the same density, but much thinner and very homogeneous in width. You've got the subchondral bone, okay? So in this point, we have the confluence of three different types of densities and structures, with the fourth one here coming from the medullary cavity. And the relationship between those different areas is very, very variable. That's what is giving all the variability of coronoids amongst dogs, okay? So whenever you see any changes, try to get this plane and cross-reference your findings in this other plane. And on the transverse, it's pretty straightforward. So we have the cortical bone, subchondral bone. In some dogs, it's so thin that at some areas you barely see it at all. And then here, we've got all the cancellous bone. And you can see that there is a very sharp transition between cortical and cancellous bone or trabecular bone. And this is what is going to disappear as soon as you start to get disease. You will not be able to see the trabecular bone, or you will lose kind of the definition of the margins between them, okay? And here we are just, so basically here we are right across the yellow band, and here we are just 1 millimeter down, when everything we are getting in is that kind of cortical bone. Now, the important thing to remember, I'm not fan of measuring. I don't really measure anything when I'm reporting. When it comes to elbows, I do not measure anything at all. Now, there are lots of articles that describe you the normal density, for example, but you have to be very, very, very careful, because you can see here that if you are within that band, you're going to get one density. I don't know if it's me making lines appear. But if you are slightly oblique, you are suddenly going to get cortical bone. So your density is going to be increased by a threefold. Or if you are in a bit of an oblique or wider slice, you're going to get volume averaging, and you're going to get a value in between. So just be very careful with any measurements. I think subjectively assessing the density works better. And one of the key things to understand is that the cortical bone and the subchondral bone are similar in density, and they are homogeneous. So when we look into this in a different window, you will see what difference it makes. So this is, I think, it may be the same image as before. So we are quite proximal in the coronoid. We start to get to the condyle there. So the tip is probably off plane there. So here we're kind of at this level, so just proximal to it. But you can see that this line, the transition is very sharp still and defined. When we go a little bit farther down, for example, here, we get kind of the buttress part of the cortical bone. And what I sometimes do that to me works more, works better than actually measuring, is I use a very narrow window. I use windows, sometimes like a brain window for looking at the abdomen. I use that all the time. And I do it also for orthopedics. The idea is to get an image that pretty much you've killed all of the gray colors on it. You're down to black and white. And you are going to center that window in a way that the slightest change in bone density is going to become very, very obvious. So here you can see the cortical bone and the subchondral bones, and they are pretty much identical in density. And the same here, going all around it is all homogeneous. Any slight changes in density, any loss of density anywhere will become very, very obvious. I will show you that in some examples now, what I mean. Now, medial coronoid process, if I go into just calling it disease, I know it's a very generic, random term. I stay away from fragmentation unless if it's properly fragmented. However, my experience, I see the literature very often talks about fragmentation. In the vast majority of coronoids that I see with pathology, they are actually not fragmented. So I just go down to medial coronoid process disease as part of the elbow dysplasia complex. And this is the result of some type of abnormal loading of the medial compartment of the joint. I know there are no separate compartments. I think particularly orthopedic surgeons tend to divide it more and approach it as compartments. So basically the medial humeral condyle, the way it interacts with the coronoid process. Why that happens, what that abnormal load, anything you can think of. So generally, for example, the radius is a bit shorter than the ulna, and then the load goes to the medial coronary process. Or something that is really difficult to conclude on CT, and I still struggle to get my head around this, is this kind of conflict between the radius and ulna, which is more of a dynamic thing. You know, during motion or a slight supination and pronation of the limb, the radial head kind of kicks the ulna in a way. Things that are very difficult, but anyway, whatever it causes it, you have a mechanically overloaded medial coronary process. And this is one of the things that I've taken longer in my career to get to terms with. And this is sclerosis. When I did my residency, for most of it, I did not have access to CT. That's how old I am, I suppose. But most of it was down to radiographs. And a lot of the diagnosis was always talking about sclerosis. Sclerosis was the cool thing to look for. You had to find sclerosis, a sclerosis up, a sclerosis down. Everything was a sclerosis. And I went a couple of years ago to one of the international elbow working group. And in a way, that hasn't changed much. I think the word sclerosis was mentioned every other minute for the whole day. And I never got, the idea very clear in my head. Firstly, I think because what I can see on my head when I think of a sclerosis is actually follows the definition of it. We are looking for bone that is harder than it should be, and it's got an elevation in density. So a denser, harder bone. And my question always, I could never get my head around this. So if it is getting sclerotic and therefore more dense, in the radiograph, it should be more opaque. So it should be more, whenever a coronoid is sclerotic, you should be able to see it better. And then I'm looking, for example, at this image here. This is the normal side. I've got the CT that goes with this, and this is the abnormal side. And here I can see beautifully this coronoid process. And here I don't see it barely at all. And if it is getting, sclerotic and more dense, why has it disappeared? So I can agree that this part is more dense, and yeah, the sclerotic thing kind of goes with it, but all of this part, it looks less dense than here, okay? And it's kind of with spending a bit of time reading and trying to get my head around this, that you start to read the papers where they've actually done histopathology or micro CT. You just take cadavers, like use the elbow and put in tiny little CT with massive high resolution. And actually you can see that what you get on the coronoid itself is osteocyte loss, increased porosity. You are going to have micro fissures and micro damage. This is all to a microscopic level. So before you see a fissure, there is thousands of fissures across that abnormal coronoid there. So basically, all of the changes that normally occur with medial coronoid disease result in a decrease in density. Okay, so you are looking for areas of bone that are less dense, not more dense. And I'm just going to illustrate this with some examples. So this is a pretty straightforward one here. You can actually see some kind of fissure that for some reason looks like more dense. Probably that is a little bit of a sclerosis on that band. But if you probably can already see it, I don't know how good the quality it is, but you can already see this is definitely less dense compared to this coronoid. And when you use a very narrow window, you can see here the homogeneous cortical bone, and you can see here the total loss of density of bone matrix gone there, okay? That is the part where you will see the sclerosis. So you can see the trabecular bone here extends farther cranially, while here it finishes around there, and there is not a clear transition amongst cortical and kind of the subchondral bone, okay? And this is just a little bit of the same on two different planes. And in that case, it's quite obvious, but it is not always obvious, particularly depending on the window that you are using. Okay, if you are using a bone window that is very, very wide, you may not be able to see subtle difference in density. So you may have to use a window that is not what you normally traditionally use for bone. You probably don't need to go into extremes as I've gone here, but you will need to make it a little bit narrower. Okay, I think it works better than measuring, at least in my experience. So here, they look fairly similar in shape, size. I think this one, it does have a little bit of a sclerosis, but you can see it is way away from the coronoid itself. And when you use a narrow window, you can see here on the left image, you've got the homogeneous density. Here, the density looks okay here. But in this part, you can see it is definitely less dense, okay? Compare that to that. And this is gonna be sometimes as much as you are gonna see. And interestingly, in my experience, these dogs are a lot more lame and a lot more painful than dogs with complete fragmentation, because those where the coronoid is actually broken, they've released the pressure on that sore point. Probably that fragment is doesn't even have any nerves getting to it anymore. So once it breaks, it's actually very often less lame. So if you have changes like this and a properly fragmented coronoid in the other side, it is very common that that is actually the painful side, okay? Because we've had that as an issue of people querying, okay, I think there's a lateralization error because the fragmented size is the other side. It's actually quite common for this to be more painful. If you are unsure, go back to that kind of oblique sagittal plane along the coronoid. You can see beautifully here the homogeneous density of all the cortical bone in the coronoid. All of it is the same density. And you can see here perfectly how that part of the coronoid, it is less dense. It's losing a bone matrix. It's got increased porosity. I don't know, Fritha, how we are doing.
Hey,
I can
Manuel.
see 29 chats going on. Yeah.
Manuel, we've got a question here from
Yep.
Kate. She says, what is an example of the sort of window and level you commonly evaluate in?
Sorry, what is that? Sorry, can you repeat that?
It's from Kate, and she
Yep.
says, what is an example of the sort of window and level you commonly evaluate in?
I will do one thing. I will go later on. Let me make a note. I will open Osirix and I'll do it. I never, ever, or really ever, look at the numbers I use with the window width and window level. I do have some starting points of what is generally like a basic soft tissue, brain, bone kind of window width, window level. And then I start working from that. I've always had the impression that very precise numbers of windowing do not really work. And I realized that because, for example, if I just jump out of bed in the morning and I go straight to my computer, I'm not going to use the same window width and window level as if I'm in the garden in a sunny day and come back into the house. I'm not going to use the same when I'm on a darker room. I'm not going to use the same when I'm on my laptop. So it's a little bit variable, and I cannot give you an accurate number. But later on, I'll open an elbow, and then I can just play with it and then see what numbers I finish with. Okay? So I hope, Kate, I don't know if that answers that, but I'll try to give a more precise answer right after. Anything else, Frida? Should I carry on?
No, that's good.
Okay, cool. So just a quick example here of a properly fragmented medial coronoid process. I thought it was worth putting one because obviously they do fragment, which is why they are called traditionally what they are called. These ones, I didn't insist much on them, but because you're not going to miss them, you've got a clear fissure, you've got the fragment there, whether it's separate or not, or kind of displaced or not, and you will have the loss of trabecular pattern there. That is the sclerosis. Okay, so that's lost density, that's increased density, and kind of you've lost that expected trabecular pattern. See, it's still maintained here, but there is completely lost. And use this randomly. I used in a talk a year ago talking about the how do these cases evolve when you follow them up on imaging. And this is a case I think was quite interesting. It's got this fissure here. It is the same dog. I think this was incomplete or about to be complete, still not displaced. And you can see with a bit of time, relatively quick, in only 3 months, the fragment's now actually displaced. But just forget the changes on that and look at the bone, what's happened. I think that's really, really interesting. You see here, all of the sclerosis here, the trabecular pattern kind of is gone. And look what's happened once the fragment is kind of actually fragmented. And I think that is releasing the pressure on the medial coronoid process. It actually looks better. And you will sometimes see the same thing when they do coronoidectomies. If you have a chance to follow them up, you will actually see the underlying bone changes resolving or getting better. Obviously, the DJD is gonna progress regardless. I'm not really sure, if this means the dog is less or more affected clinically, but you will start to see obviously DJD appearing. So incongruity, which to me is the main thing we should technically be assessing when you are looking at elbows, because this is probably the source of all of other issues, is actually extremely complex, and it is very difficult to look at it. I look at this very subjectively. Again, I don't measure things. I know some surgeons will make decisions based on specific measurements. Is it more than 2, less than 2 millimeters, whatever. I think most of those measurements do not work. Personally, at least I cannot reliably get similar numbers when I redo that thing a few months after. I can see some geometric incongruencies in the way, or things that are not logical in my head as to why we measure things in a way. And just to add a little bit more to it, is like something like, for example, let's say you've got the radius and the ulna that have different lengths. That is more of a static thing. You should be able to prove that relatively well on a CT, but things such as radioulnar conflicts, this, and even humeroulnar kind of congruity, these things change with the position of the limb probably. So when the dog is bearing weight on it, when the dog is moving, these relative positions of one bone towards the other are likely to change. So with incongruity, I think it's very difficult to get good reliable reports among radiologists. People look at these different ways, but it is critical. And the frustrating thing that you will see for example, let's say if I'm saying that abnormal coronoids are because there is some kind of incongruity, you will very often have what looks on CT perfectly congruent joints, and the coronoid is fragmented or is grossly abnormal. So I think most of the incongruities, when it's subtle but severe enough to cause disease, we actually don't see it on CT. At least that is my impression. And I've just put a screenshot of a paper I'm sure most of you have read, just to show that if you like measuring things, there are many ways described there. But when I try to apply this to actual cases, to me, it doesn't really work. And I think some of the reasons is the geometry of the measurements themselves is probably not correct. I don't know if I can, hang on, let me just try one thing. Is it P? Yeah. So for example, here they're measuring this distance, and this is a well-known article, and it's a valid paper probably, but they try to measure this distance, but this distance is going to be determined by many things, particularly the distance between the radius and the ulna, which is something that it is very variable. Where to me, radio-ulnar incongruity, for example, would be differences in those two distances there. I don't know if you understand what I mean. This distance, if the ulna goes a little bit more caudally, which happens in some small dogs, then you start to get measurements that are telling you there is significant incongruity, and actually the joint is perfectly congruent. And the same goes here. When you look at this medial part, this part of the radial head is very variable. So it's kind of supposed to follow the humeral condyle like that. But in many dogs, it's actually a bit flatter. And that you will see if you start to look at the elbows in normal dogs that are having CT done for something else, you will see that that is very variable. So this distance here very often will be increased in dogs that are perfectly asymptomatic. So that is where is the challenge to decide that just an anatomical variant or this is some degree of subclinical kind of incongruity. I don't know. So I try not to measure things, and I try to work with my standard kind of the planes that work for me. And what I'm looking for is very, very simple. You are looking for articular surfaces that are perfectly parallel one to the other. So the width of the joint must be homogeneous, and you should be able to see that all the way around. And the same goes here. In this part, you're looking for the joint to be perfectly parallel surfaces. And here is where it's very variable in my experience. The radial head doesn't always reach out to the top, but then kind of the same thing here. Okay, and be aware that if you put stress on a limb, if you, particularly when you are pulling them and you, let's say, for example, you try to bring the elbows together, it is very often that you are going to open up the medial compartment. So you will open a little bit that depending on the position. Okay, so you need to allow for some margin of positional changes and anatomical changes for this. Just some examples of very fairly obvious, straightforward kind of incongruity. Humero-ulnar incongruity, where this joint space is widened, is a very controversial one. This one, there are lots of articles that say that some degree of this type of incongruity is physiological. I don't know what the truth is. I normally describe it on my reports, and I would mention that this can potentially, to some extent, be incongruent. I don't think to this point, sorry, this can be actually physiological. I think that has to be pathological there, okay? So that is kind of a tricky part of the incongruity to say, but this one is, for example, pretty clear cut. You actually have the sclerotic bone in the condyle there. You can see this is very narrow. There's probably not even a space there for cartilage. There has to be cartilage gone there compared to that, okay? And yeah, all sorts of severity here. So a fairly similar case, typical medial coronoid disease where you've got a bit of a longer ulna than radius. And here you can see that this, instead of being two parallel lines, you can see the radius of curvature of the condyle and the radial kind of the semilunar notch. They are not parallel. So there is some kind of discrepancy in the radius of curvature, and or the humeral condyle is displaced cranially in relation to it, okay? So this can sometimes happen. I've had this debate a few times where you can just have this because of increased pressure there with a little bit kind of a fusion. I'm not sure if that's true. So this one is difficult to interpret, but you can definitely see the step here, okay? You don't need that to be 2 millimeters to be very severe, okay? At least when measured in that direction, okay? That and that should be perfectly aligned, okay? As is in this dog in the other leg. You can see that width there compared to that, they are pretty much identical, because it's the same dog, two different elbows. So I think, yeah, medial coronoid process is probably the most challenging part of elbow assessment. And now what we're going to move into is a lot more straightforward. United anconeal processes, the anconeal process itself, you are going to see it as fragmented. There is no magic. I mean, this is very easy diagnosis to make. but you need to be very careful that you can identify and rate the severity, at least subjectively, of the cause of this. And this is the incongruity. So if we look here, this one looks a little bit increased there, but yeah, I think, see, that is increased as well. The radius and the ulna are pushed away compared to the other side that is a little bit more normal. And this is what is generally causing this. So the ulna is a bit shorter than the radius, and that means that the condyle is gonna kick the anconeal process proximally. And this is important because I think the surgeons are gonna decide what to do in these cases based on the width of the joint and how big the step is. So you can see, for example, here how that kind of, you don't even know where it's going, that coronoid there, but you can see it's definitely going nowhere near what it's supposed to be. And this is a very severe case. So look at the kind of the semilunar notch. That line is supposed to go up there. Okay. So those things you need to look. You need to look for comorbidities as well. This is something that kind of always surprised me. You know, when I was a resident, we were doing a lot of screening for healthy dogs for breeding purposes, and you would see anconeal processes fragmented in perfectly sound dogs. So just because it's spectacular and, you know, wow, what a big fragment there, you know, you still need to look for everything else. You see, for example, in this dog here, actually, you've got the sclerosis there as well. It's got very severe panosteitis. So you're going to need to decide, you know, which one is lame. Or it's not something you can say on a CT, but maybe you need to be careful that you mention that as a potential cause of the lameness or a contributing factor, you know, and maybe just wait to see the progression, because obviously, you know, the progression will be very different. It will be self-limiting for the panosteitis, while the other one may just progress. Okay. Kissing lesions and OCDs. I put slash as I do in my reports. I do not attempt to differentiate this. I think this is the most pointless argument I've ever had, and I had it many, many, many times. Are these the same thing? Are they different things, or the same pathology occurring at different stages of bone development? I don't know what's the point of the debate, because I think they are going to treat them in the same way. So just to make sure I kind of get it right, I just put both on my personal reports. That's how I do it, because otherwise you start into kind of an endless argument. And this is going to happen when you've got the medial compartment again. So this part of the joint being overloaded. In the same way the coronoid reacts, the condyle may also do so. And in the condyle, you do see proper sclerosis where the trabecular pattern is gone and you've got increased opacity. Sometimes that's all you see. In other cases, like for example, this dog with also coronoid disease, you do see a defect as such. Okay, you can see the little hole and you see the sclerosis. And very interesting, for example, in this case, do you see the sclerosis here? But do you see it's very abruptly, sharply, it's got that band going up of normal kind of bone. That's where the fragment is taking place. You will see this whenever there's a fragment coming off. This part of the condyle is not overloaded anymore. It's a little bit like with the coronoids when they break off. So therefore, the bone perpendicular to it is not really being overloaded and doesn't get sclerotic. So the sclerosis will sometimes resolve in the area where the fragments occur. Okay, but MPRs are critical, particularly in the sagittal, because these things can look very small in the transverse or in the dorsal. And in the sagittal, this bone rubbing, every time the joint does like that, is rubbing there. These tend to be much bigger on the kind of craniocaudal dimension compared to the dorsal plane. Okay, so that's very critical to look on MPRs too. And that's just another, yes, an incongruent joint. And here you've got definitely a big kind of pocket there. And look how big the defect goes from there to there on the sagittal. Okay. So I don't know. Yeah, there are lots of debate about this. You know, if it's more lateral, it's more likely kissing lesion, or the other way around. Or again, it's not a debate I personally try to open. I mean, I just put both things with a slash in the middle. I know. So I'm not sure, guys, if you are aware of any relevance to get the right diagnosis amongst those two. Just say it, because I just think treatment-wise, it's not going to change much. For the degenerative joint disease, very straightforward. You're looking for periarticular surfaces that are smooth. So a little bit, you know, I started as a radiologist with radiographs, so I still rely a lot, not on the radiographs, but on getting CT images that kind of match those images. So for example, a lot of the way I do the sagittals, I try to make them look like radiographs so I can see those same things, okay? And I think particularly for the radial head, also for the anconeal process, on the transverse plane, it's quite easy not to see them, okay? Particularly up here, you may need to go a bit parasagittal to find kind of the little kind of blobs of new bone appearing there. In degenerative joint disease, as for other joints, sometimes it can take an appearance slightly aggressive. You can see here almost looks like palisading, very regular. I mean, I'm in this case, in fact, I do know what it is. This is just DGD, so I didn't put cases with an open diagnosis. but sometimes in these cases, you are very tempted to try to conclude into, you know, is this bone reacting to infection or something a bit more aggressive? Just be aware, as we will discuss later in more detail, that sometimes you will get very aggressive DJD changes, okay? One of all the degenerative changes to look for, you can see here the medial coronoid process density is abnormal, and you can see that density extends very, very often along the radial notch here. Okay, you will see that band or even fissures developing in that way. And particularly in the central part, you will get kind of these lollipops here, these kind of lytic cystic lesions. And those are nothing to worry about. Well, nothing to worry. It's just part of the degenerative process. So it's not necessarily anything aggressive, anything lytic as such as something chewing bone away. So I think for bone changes, I'm going to leave it there for now. I don't know if there's a question or should we continue? I don't know, Frita, how are we doing?
Naomi has a question. So
Yeah.
how can you tell the difference between an osteophyte at the medial coronoid process and a fissure, or a fractured osteophyte and medial coronoid process fragment?
I don't think I can. Yeah, it's a very good question. I always thought you can. I mean, I normally would look at the shape of the coronoid itself. Particularly, you've got the contralateral, something I did not mention, but that's my advice I always give to absolutely every single one of our clients and to everyone. You never image one joint only. I think for all modalities, actually. Because you may be lucky, and if you have the other coronoid and it happens to be normal, for example, if you compare the shape, you may be able to better decide if there is an osteophyte kind of extending, projecting kind of cranial or medial to the coronoid, or if it's actually a fragment that is come off. I don't think you can, and I think it's also very variable depending on the timing. So in very early stages, if there is a fragment, you will see the bed where the fragment is come off. But with time, that fragment may actually kind of reattach itself as a large osteophyte, or, you know, things progress. So I personally do not think there is a definite way in many cases. I think generally you will be able to see the defect because you see the fissure, you see the abnormal kind of the chunk missing of the coronoid itself. But I don't think I've got a clear answer for that. I don't know if that answers it.
Manuel, we're basically out of time here. So if you want to sort of start wrapping up.
Okay, are we up out of time? People have lots of plans during quarantine. Okay, hang on a second. Basically what I was gonna move on to, I'll do just very, very quickly then that part. Joint effusion is pretty straightforward, guys, if you know where to look for it. On the transverse plane, you will be able to see it, like for example here, compare that side to the other side. You can see the fat, so there you have like fat pads as well, as you have on the stifle. So you will be able to see the effusion there compared to this one that is normal. And you will see it even better on the sagittal plane. I think you see it better. So that's the normal capsule with a bit of fluid. Well, here you've got all of the effusion with the fat planes pushed up and so on, okay? And the same thing proximally in the anconeal fossa, you will start to see the capsule bulging out. If you look into human literature, they call it on the radiographs, they can see it quite well in humans. I think it's a sail sign or something like that, okay? Yeah, I was just gonna have a few comments about contrast, which I think for elbow dysplasia, it has no real application. You may be able to see a little bit cartilage, but it is very, I don't think it's reliable enough. I think if you really, for some reason, the surgeon needs to know if the cartilage is intact, then they just need to put a camera on it, okay? And I'm just gonna move through this quickly because we're running a bit out of time. Use some of the pitfalls that I wanted to mention this very quickly, just 3 slices and then we're finished. Be careful with incongruity. Make sure that you can recognize the plane you are on. You can make pretty much any elbow appear incongruent if you start to do weird oblique planes. So try to stay within planes that you are familiar with. And if you think it's incongruent, try to change the plane until you get an image that is more familiar. Like for example, here you start to make the joint appear wider. And these are, I really want to mention these ones. I'm sorry, it's just 2 slices, but I've seen this, and this can have very dramatic impact on your patients. Some types of DJD, sometimes the DJD can look extremely aggressive, okay? And having lysis like this, it is not all that uncommon, particularly when it's extending from the supratrochlear foramen. So from the foramen, proximally or distally, you will get huge holes. This is just another case. You can see almost look like a scooped out appearance. This tends to also cause massive effusion. And you've got another case here, you know, with all the invaginations. That's generally a synovial kind of proliferation that extends into the bone, okay? Just be very careful, particularly when you look proximally, got this gigantic here osteophyte. And when you have things like this, there's really a bit of a hole in the area. You can see here a little vascular foramen, but you can see there's here an actual lytic defect. And that actually pushes everything up, all the synovial membrane and the synovial fluid goes up into the joint. And when you look at a soft tissue kind of window, even if it's a bone filter, but the window, you can see there is soft tissue material there. Very often it's synovial membrane, and it will enhance, delimited by a bit of a sclerosis generally. So it's very tempting to start to think it is actually a mass growing towards the joint or something. So you be very careful of any kind of lytic defects, proximal or distal to the foramen there, okay? Just another random example of one with IOHC, where you can see all of the synovial invaginations there that can make this look very, 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 very aggressive, okay? So it would be a dreadful kind of thing to do, because the end of the dog may be, you know, maybe this may result kind of an amputation or worse, okay? So I went a bit too quick at the very end. I tried to speak slower, and I don't think I managed. So hopefully that didn't make it too long. So I don't know, Frida, how we're doing. I don't know if we've got any more questions anytime. I was going to mention quickly about the window width, window level. I don't know if we've got any other questions.
So I don't have any questions on the list. Does anyone have any more questions that they want? Got one person. Okay. Do we have any other questions before we finish up?
No, I was gonna, if you have 1 second, I was gonna show very quickly my Osiris about the density thing. So I've just got a coronoid here, and I normally go all the way down to around that area, which is gonna be, where is my window? So I'm around the 1,000, yeah, level is 1,000. All right, yeah, so yeah, the width and the level are about 1,000 both, okay? So I don't have a specific value, but just try to make it look very black and white, basically, okay? And as soon as you start to change, you will start to see all the changes a lot more conspicuous on the image. All right, I'm gonna stop sharing. Yeah, there we go. So yeah, sorry, I was, Frida, are we good? Yeah, I know we are run out of time a little bit.
Yeah, so we don't have any more questions that are popping up. So thank you, Manuel. That was really great. I think everybody enjoyed that. So that was a really wonderful talk. Thank you. So everybody, the next session is going to be next week, Wednesday, April 15th, and it's Dr. Tobias Schwartz talking about abdominal CT part 1. So we hope you will be able to join us for that. You will receive an email with an automated registration link, like you did before today's session, and it will come just before next week's session, and that will be the same for all future summit speaker sessions. If you're unsure or have any problems with registering, or if you know others who wish to join, just email us at academia@vet-ct.com, and the link should be coming across now. These talks will be at the same time each week, but please remember that daylight savings affects your time zone. So just double check you have the correct time before you sign in. A big thanks to everyone who's coming from the West Coast of North America, who woke up very early for this talk, and for those of you who came from Australia and New Zealand, because you came on very late at night, so we appreciate you coming in. Today's session has been recorded, so we'll put that up on our website so you can have another watch of it later if you'd like. If you have any questions about our resident support plans, you can send us an email at academia@vet-ct.com. So thanks so much for attending. It's so great to see so many people coming together. That's been really awesome. Stay safe, and I hope we'll see you all again next week. And again, if you have any questions, just send us an email.
I was just going to say, sorry, Frida, to interrupt before you close. I was going to say, if anyone wants to discuss any of these things further, agree or disagree with some of the specific things, please just reach out, okay? What we do is most of the time is discussing elbows. I think that's about 1/2% of my time. So just don't hesitate to reach out, okay?
Thanks, everyone. Stay safe.
All right. Bye, guys.
Bye.